too.
We can forward to him.
We can forward
I'm
it
good,
out.
I'm good with going.
Tired of?
Yeah.
I think we already have that, right? We all got that. But I know my students always like to make fun of me, and I don't care. It helps you
It
remember,
helps us
right?
learn. Yes, it did.
It helps you learn. So, all right, so this semester, we're gonna get into a lot more of the technical stuff. Parameters, what to change, when to change, what happens when you change. Changing one parameter can make a huge difference in your entire scan between, or let's just say collectively, your image contrast, your time, a lot of different factors that go into it. So you change one thing, sometimes it will change other things. So we always have to really know what our parameters control and when to actually change them. You know, so I know there's a lot of texts out there that it's a time thing, and I get it. You know, where I work, it's every 30 minutes. And that first 7 o'clock patient, like happened to me this morning, comes in at 7:05, I'm not getting them on the table until 7:10, 7:15, my day's already screwed. I'm already behind. So we're always looking for ways to shave a minute here, a couple minutes there, so that we can do some catch up. And that's all well and good. In a perfect world, patient comes in on time, you get them on the table, you know, at their scan time, and you have 30 minutes, and you don't have to touch any of the parameters, okay? We don't live in a perfect world. So what we're gonna do is we're gonna go over the different parameters, all of the parameters that we use to change things. The 2 parameters that we've already learned that should be stuck in your minds are TR and TE. TR controls. What else? Number of slices, okay? TE controls your RT2 contrast. So when it comes to a timing thing, does TE control or have anything to do with time? No. The answer is no. TR, it does. Who can tell me or explain how TR controls our time? Go ahead, Mike.
Well, if you're sending a signal more frequent, then you're.
What's the other thing that TR controls besides T1 contrast? Number of slices. So how does that come into play for time?
More slices, more time.
More slices, more TR, right? So if you don't have sufficient TR to acquire the number of slices that you have, what happens to your time? It's longer, basically it doubles, okay? So you always want to make sure that the number of slices that you've selected or that you've programmed, that the TR is in range for it. My GE brats that are here, on the GE system, it tells you on the bottom of the page, total number of slices per TR. So if I have 24 slices and the TR that is set in that protocol is for 23 slices, what do I need to do? What do I need to do? What? Don't you be touching the thickness. What do I need to do? I need to bump my TR up to accommodate those number of slices. Okay? So remember, in any system, whether it be GE, Philips, Siemens, the protocol that gets set, the original protocol that gets set, is set for that patient that you saved it for. Okay? So when we first set up an MR system, we save protocols. I'll scan a brain, okay, everything was good, you know, my contrast was good, my signal was good. That's a good protocol, save protocol. That might be on James Smith. John Doe comes in and I have to do 26 slices on his brain, axial, instead of 24 like I used on Jane Smith, who the protocol was saved on. Does that make sense? So the protocol that's in there doesn't necessarily mean you can only do 23 slices. Okay, if it's saved that way, it was saved to accommodating that particular patient. Everybody has that, right? So if we use more slices, we need to increase our TR. What other parameters have you guys noticed or touched? Let's say changed or played with? Bandwidth. Why would you play with bandwidth? Keep going. That's all you know. That's all I know. What do you do with the bandwidth if patient has metal? Okay,
Whatever is already set, they just double.
but they don't know why or doesn't tell you why. Sorry. Okay, we're going to get into bandwidth, and we're going to go over what to do with bandwidth and how it affects our signal and our time. Give me another parameter that we've played with.
Concatenations or acquisitions, I guess, is GE.
Okay, so when would you,
We tend to do it especially with like MRCPs or abdomens to lower the time so they don't have to hold their breath as long. Like it's
Okay.
broken up into that number of breath holds. Or
okay, take it out of the breath hold concept. Can anyone take that out of the breath hold concept? Number of acquisitions or concatenations?
Reduce motion.
What's that?
Reduce the motion. Because it cuts the time in the second.
How about this? I'm going to give you a scenario. You're doing a T1. Okay? What are the parameters for T1?
less than 650 or so.
Or let's just say a short TR and a short TE, right? Okay. So good though that you threw a number out there.
Mhm.
Let's say 650 or less. So let's say I have 24 slices. My protocol was 22 slices. My TR was set at 620. If I bump up my TR, why would I bump up my TR?
For the slices.
Because I increased slices, right? So I have to accommodate those slices. So let's say I bumped up my TR, and my TR went to 700. No,
You're
because
eliminating.
TR does not control T2. What's going to happen?
Eliminating your T1.
You're going to eliminate T1. You're not necessarily going to get a T2. That's the point I'm trying to make, okay? You're not going to get a T2. You're going to diminish your T1, right? That's not good, right?
Mhm.
So if I back my TR down to 400, what happens? Instead of getting one acquisition, I can do it in 2 acquisitions or 2 concatenations. Make sense? So that's another example on when to change your acquisitions or your concatenations. Make sense? All right, give me another parameter. The next. Why would you play with the next? First of all, what is next?
Number of samples.
Okay. Number of excitations, NSA, number of signals averaged.
I've seen them use it for like decreasing time. So it takes less samples, so it's less time.
Okay. So what else happens when you do that?
You're reducing your, you're reducing like your image resolution.
Your signal. You're losing signal,
You're losing signal, okay.
right? So the reason they're playing with that is why? to save time.
To save time.
They're definitely not doing it to increase image quality or signal, right? Okay, so that's one that I wouldn't play with. Unless, of course, the patient's flailing all over the place and you're trying to get the patient done and you've got to get him in and out. Okay? I'm not saying to never touch it, but in a perfect world, that's one that if you're looking to save time, try not to touch. Sure.
So if you, with that being said, as far as if you decrease your max and you're, reducing your signal and stuff
Right.
like that, are you able to make up for that with adjusting your pace
Sure.
and your frequency?
Sure, you can make up for it in other places. That's why, this is where we're gonna go this semester. I wanna make you guys think, okay? Know which parameters to play with, when, and if you're having to cut time and cut at one of these parameters, that's really, really important to our signal to noise, how we can make up for it somewhere else. Okay, so this is gonna be more of a, instead of a lecture throwing at you guys or this kind of stuff, it's gonna be more of thinking. We're gonna think it through. Okay? Give me another parameter then. Field of view. When would you play with the field of view?
I know when the field of view is either a square or a triangle. So when the face direction is from left, right, or head to foot, and I'm gonna for time.
What is field of view? What is field of view?
Field of view is what you really see in one of the slides.
Just what it says, field of view. What you are actually imaging.
Right.
So if you change your field of view, why would you change your field of view?
Because if you have a smaller field of view, you have a better resolution.
I'll go with that. But in a everyday setting, on an everyday patient, fine. Did you say that? You're raising what?
When you see more, when you see less.
True. So let's say protocol for sagittal knee is at 15 or 150, depending on what type of system you're on, okay? So, and the patient's 280 pounds and their knee's about this big. So that 15 field of view may not cover all the anatomy in that knee. So that is a time, that would be a time, obviously, to change your field of view. What happens when you change your field of view? I know that your anatomy is more or less.
It might change the phase axis because the phase axis is a short axis.
Let's not go there yet.
You have to increase your slices.
Increase your time.
Decrease your time.
Field of view has nothing to do with time. Field of view has everything to do with what?
Resolution.
Signal. Okay, so think about it. And this is another one of those parameters that you're not every day going to go in and, hey, I'm going to get some more signal, so I'm just going to blow this sucker up. You're going to change that field of view when you don't have a big enough field of view that to contain what you're imaging. Okay? Any other time, you're not touching it. But field of view has nothing to do with time. Okay? Field of view is related to signal. It has everything to do with signal. What is another parameter? Slice thickness. When and why would you change slice thickness?
When one to cheat a little bit.
There it goes. There it goes. So what would you do with your slice thickness?
So when
Would you increase it or decrease it?
no, if I want to cheat,
I'm going to cheat. I'm going to increase it, right? So that I use less slices to cover.
yeah, that's
Thin area.
Be careful because you're going to get your hand slapped one day by a radiologist that says, well, we're supposed to be doing 3 millimeter slices. You're not 4.
I don't go for.
So that's not that. There's another example. That's not one to change. We're gonna learn the time-saving ones that will benefit us, not hurt us. Give me another one.
Phase oversampling.
Okay, tell me about it.
That deals with your wraparound on your images.
Okay,
Um,
keep going. Let's wrap around.
Depends upon your, you should say the field of view.
Exactly.
Depending upon the anatomy.
Exactly.
If the box is covering your field of view, if there's anatomy outside of it, that can wrap around and come into the other side of the picture. So
Very
you want
good.
to increase your oversampling.
Okay, so you can do two things there.
Mm-hmm.
If the anatomy is not fitting in your field of view, you can
Make the
change your field of view.
Right.
A lot of times that's frowned upon, by the radiologist. Or you can use oversampling, which is Siemens or Philips?
I'm on Siemens.
Siemens. In GE, anybody know what it is on GE? No phase wrap.
No phase wrap?
And PW, no phase wrap it's called, okay? So it oversamples so that that anatomy that is, here's the perfect example, when you do a sagittal brain
Mhm.
and you got that nose sticking out, okay? And if you don't have the field of view big enough, or your field of view is already, big enough, you turn on no phase wrap or oversampling so that that nose does not appear to be sniffing into the back of the head. Make sense? Okay, that was a good one. Give me another one.
What is graph points?
Contaminations?
We talked about that one.
They grapple,
What's that?
they grapple. They grapple on the cement sometimes.
What's it called again?
Grappa.
Oh, grappa.
The crosstalk?
It's in the resolution, the iPad. They select the grapple or they turbo warp it sometimes.
That's probably like on the GE Zip 2, Zip 4. Yeah, that's in imaging options. I'm more looking for your matrix. What is our matrix? What is the matrix? What's that?
Number of pixels.
Okay. Can anyone elaborate on matrix?
Phase by frequency. Matrix.
Phase and frequency. Go on.
As the number is bigger, the resolution is better, as the pixels are smaller.
Okay. So if I want high resolution, what type of matrix would I use?
Higher number.
Five.
Fine matrix, which is
Large.
the larger numbers, 512, 384. Nobody ever scans in 1024. If I want more signal, what type of matrix would I use? A coarse, which is the lower number. Remember, coarse matrix, lower number, the pixel size is bigger, okay? Because the lower number, let's say 128 by 128, to fill that field of view, let's say it's a 24 field of view, bigger, the pixels are bigger because there's less pixels. When you go to a fine matrix, which is, let's say, 512 by 512, that same field of view, now you're shoving 512 pixels into that same field of view, so now they're teeny tiny, but that affects our resolution, okay? I always like to use the example in our MR book. It shows the picture, let's say at 128, and the pixels, the big square pixels, and it's fuzzy, right? Then you take the 512, got a little itty bitty pixel, and you can see every detail in the woman's face. You can see her eyes and her hair, right? And it looks like a picture. There's more resolution, there's more detail. Okay? All right, so I think we covered the majority of them, and I'm glad that you guys remembered these things. I know we touched on them last semester. you know, I threw little lines out to you guys here and there, but I'm pretty impressed that you guys retained it and remembered it. So tonight we're gonna start with parameters and trade-offs. And we're gonna take some of these tonight and break them down and see exactly what they do. Make sure nobody falls asleep. Is that gonna help? Okay. So, little review of image weighting. It's determined by three main things, right? The TR, the TE, and the flip angle. How does the flip angle affect image weighting?
Because it takes how long it takes for one to recover, like if it's a small flip angle, then one of them will have the chance to recover fully.
Yes. When do we change our flip angle? First of all, what is our flip angle? What's that? What is the flip angle? What is the definition of flip angle? What does the flip angle do?
Other than 90.
All right, here we go. What does the flip angle do? It flips the spins from the longitudinal plane into the transverse plane, right? That is known as a flip angle. In a spin echo pulse sequence, what is our flip angle? 90. Why is it 90? We want to take all those spins from the longitudinal plane and flip them exactly 90 degrees into the transverse plane, right? Okay, so spin echo pulse sequence requires a 90-degree flip angle or excitation pulse, same thing, okay? When we do a gradient echo, what happens to our flip angle? It's a varied flip angle. It's less than 90. So what does that mean to us? If the flip angle is less than 90, what happens?
Less spins.
Less of our spins are going to make it into the transverse plane. So there's a couple things that happen because of that. What is one? It's less time, it's shorter, less signal. Because less of the spin, not all of those spins are getting flipped into the transverse plane. So if I'm going to, what does our flip angle determine? If it's a variable flip angle, less than 90, how does it affect image weighting?
Acute angle is 40 or large angle is 40.
If I want to do a gradient echo, which requires a variable flip angle, what kind of a flip angle am I going to use to obtain a T1 weighted pulse sequence?
Large.
A large flip angle. Okay, why?
Allows for recovery,
Why is it?
allows for the recovery, recovery time.
Okay, TR controls T1, right? TE controls T2. Flip angle will contribute to both T1 and T2, depending on the size of the flip angle. So if we want to get a T1 weighted gradient echo, we want to use a larger flip angle. So more of those spins get over and can recover, okay? If we want to do a T2 weighted gradient echo, we're going to use a smaller flip angle, or a proton density is also going to use the smaller flip angle, okay? So these three parameters are really key when it comes to image weighting. TR for T1, TE for T2, and then your flip angle for T1 and T2, okay? Okay, so T1 weighted is altered by TR and flip angle. This is just a little bit of a review. T2 is altered by your TE. So when we're talking about our image quality, we have 4 main factors. You guys, let me know, shoot me a text tomorrow if any of you go on Blackboard to let me know if the PowerPoint's made it over. I don't know what happened, why that happened, but just someone shoot me a text to let me know. Anyway, so we have signal to noise, which we've talked about, SNR. We have your contrast to noise, CNR, spatial resolution, and our scan time, okay? We're gonna break all this down. All right, so the ratio of the amplitude of the signal to the amplitude of the noise received by the coil, we always want more signal, less noise, right? Right?
Yes.
All right. Noise. Every patient, every scan you do, there's noise present. It's how we control how much gets through that contributes to our image. So noise gets determined by 2 things. The patient's body composition, okay? And inherent noise, background noise. Sometimes there's just no controlling of that. There's always a little bit of background noise from the system itself, okay? All of the systems out there should get preventative maintenance, or what we call PM for short, preventative maintenance quarterly. What happens for a PM, the field engineer will come in, they run a bunch of scans, they check for the center frequency, they check to make sure that isocenter is in the center. So, I mean, this happens to any type of equipment, whether it's x-ray or even your car, right? If you don't take care of it, things start to go wrong, right? Or things start to kind of slip. So quarterly, the field engineer will come in and do, usually ours takes like 2.5 hours. He comes in, he runs phantoms, he checks for the center frequency to make sure that isocenter is centered. Make sure that when you set your slices up or you set a scan up, that it is centered, okay? Sometimes the systems can veer off and be off by 1 millimeter or 2. It happens. So quarterly, we have our field engineer come in, runs all kind of tests, make sure that everything, that the shim is good and there's no outside interference coming in to contribute negatively to the scan. So noise is going to occur randomly, but in all frequencies, okay? So there's always going to be a little bit of noise present. Okay, so signal, we know, is the voltage that's induced, right, in the coil after the patient, after we get those hydrogen protons all excited, right? Then we listen for the signal gets picked up by the receiver coil. And then, signal is not random. Signal is something that we can produce and reproduce and keep producing, right? We know how to control signal. We know how to get signal from the patient. So it's not random. It's reproducible. It is cumulative. Okay, we can duplicate every single time. Signal is increased or decreased relative to the noise. If we do it, let's say we do a scan and it's pixely, it's noisy, we don't like it, we can change our parameters to make it pretty, right? Okay, so we can increase it or decrease it. Let's say we have a ton of signal and our scan is really, really long. We don't want to be doing 5, 6, 8-minute scans on patients, right? Signal might be out, out the ceiling, out the roof. But if we can break it down a little bit, make it shorter, then we'll try to achieve that. Okay, so The ratio of the amplitude of the signal to the amplitude of noise received, again, we want more signal, we want less noise. That was a double. Okay, so factors that influence our signal. Proton density. What's proton density? It's the makeup of the patient, right? Okay? The voxel volume. How big our pixels are, or how small our pixels are, right? The type of pulse sequence. How does the type of pulse sequence dictate signal?
Depending on, if you're getting rid of all the, if your sequences, like getting rid of all the,
So give me an example.
180s,
Give me an example.
like if you're doing a gradient equipment, you're getting rid of all the metal, so then there'll be more noise,
Why? Why aren't you getting rid of the noise?
because it's a very low flip end of stop.
It's not the flip, it's the rephasing.
Right.
Okay, so if we do a spin echo pulse sequence, what is a spin echo pulse sequence?
So 90
degree falls
followed by
down,
180.
What does the 180 do?
it pushes all the
Cleans up.
wanders out of.
It cleans up the crack. It helps to clean up the image, right? So that 180 rephasing pulse is used to clean it up. When we do a gradient echo, that gradient cannot clean up those inhomogeneities. Why? When we're using the 180 sweeps past the transverse plane so that they don't contribute to the image. When we do a gradient echo, how do we rephase a gradient echo? With another gradient of opposite polarity. So what happens? It stays right here. That means everything stays right here. Okay? Those inhomogeneities cannot get pushed past the transverse plane, so they're going to contribute to the image. Very good. Timing parameters, RTR, RTE, and our flip angle. Number of excitations, NEX, NEX, NSA, number of signals average. Our receive bandwidth, and the type of receive coil that we use. So we kind of broke these down without any slides by ourselves. I'm really impressed with you guys, that you threw out pretty much all of these, okay? So how would the type of receive coil dictate or contribute to the signal? What is the rule for coils? How do we choose our coil? We pick the coil that best fits the body part. Very good. I mean, it's simple, right? So if we're going to do a wrist, we're not going to use the head coil.